in conflict, particularly categorize them here into non-clinical on the left and clinical ones. So for the non-clinical ones, we would start with obviously an issue of access. Tom already explained that, so we're not going to go back into that. But that obviously has to do with safety, logistical infrastructure, financial factors, and so on. And then we have often that might lead to delayed presentation of the patient to a burns unit or to the facility where you will be treating that patient. Now, that will have a direct impact on the rehabilitation. Perhaps patients come in with already existing complications such as contractures, infections, and so on. And so the left basically really impacts what you see on the right as well in this table. Now, with in conflict, as we already heard, there's a high chance that there might be some associated injuries next to the burn injury itself, and commonly, particularly if there is a mass casualty event, so if capacities are overwhelmed, there is a high risk of overlooking those associated injuries, especially because the burn injury is the most visual injury at first often. Sometimes that could mask other associated injuries. So it's important to be aware of that and carry out a proper assessment of the patient when they're presenting. And then, of course, also malnutrition is something we'll touch a bit more later on. So really it's just to introduce you to some of the more non-clinical aspects, as well as access to clean running water. That could be an issue, particularly when it comes to infection prevention and control, then more on the clinical side. And then, of course, if there are limitations in their resources, such as the staff to patient ratio, there will be a need for more triage, for assigning different levels of priorities to patients. We have to make do with different consumables and also with nutrition, which are quite important in burns patients, and we'll talk a little bit more about that later as well. Now, one of the issues that we face in the rehabilitation of burns patient is that often there's a lack of awareness of the importance of rehabilitation, particularly in the acute phase. And so rehabilitation is often not prioritized in that phase, and that might have to do with many reasons. On the right side, you also see a point saying that there's often it's perceived as being unsafe. Yeah, so if you have a patient with open wounds, maybe patients are still bleeding. Often loads of therapists and rehab staff would be like, hands off, we're not going to touch this patient, they have to rest, they're in pain, they need to be comfortable. And so those and others are many reasons why rehabilitation in burns is often not prioritized. Now, with the limited resources, we would often also see early discharge of patients, too early for us to really follow up on the recovery of the patient, both of the burn injury itself as well as the functionality that's associated with that. And that is particularly problematic because the length of the rehabilitation, which can really take up to years, is something that is, it goes beyond the hospital phase, and really requires, also comes with higher expenses, which if you are in an area where there's high out-of-pocket payments, this could, of course, be an issue. Particularly, lots of patients, and their families, once they are hospitalized, they have open wounds, they think, yes, my wound is eventually just going to heal. Maybe I need some surgery, maybe not. With dressings, eventually it's going to heal, and I'm going to go back to how it used to be before. However, often a lot of patients are not aware of the impact of scarring. That really requires a lot of patient education. And then, of course, because of access issues, as well as being potentially internally displaced or externally displaced, there is also a loss of follow-up with patients, particularly in this phase, where they would need that rehabilitation, where they would need that scar management, and so on. So, so clinically, we would see all these different aspects that are challenging in rehabilitation. These are primarily ones that we would see in the acute phase. And in addition to the first three that I've already kind of mentioned, there's patients often present with a lot of pain, a lot of fear, and other psychological challenges, which are very difficult to cope with. And together with that hesitation that we often see to actually rehabilitate those patients, they are undergoing potentially a lot of immobilization from the surgical procedures and from other aspects of the burn care. And those will then lead to complications that are associated with bed rest and immobility. One of those complications, one of the most severe complications, are scar contractures. And then, of course, it becomes very difficult to maintain range of motion and physical function. So we're going to go a little bit more into some of these aspects in the next few slides. But I first wanted to go over a bit of a definition question. Now, rehabilitation in burns particularly used to just start at the moment of discharge, and discharge usually coincides with the moment that the wounds are closed. Yeah, so all the surgical wound care has been completed, and they're discharged from a surgical perspective, discharged from hospital, and then rehabilitation starts. Now, what we are advocating for a number of years, yet the implementation of that has been lagging and has been a little bit behind, is that we want to move this old definition towards early rehabilitation. So rehabilitation really starts at the moment of admission, right? And we'll go over what that really looks like then. This is also to say that I would primarily like to focus on this early point and what that really includes. Right, so there's a number of different tools that as a therapist and as a rehab staff, as a part of that rehab team, you can make use of, right? So this is the toolbox, and I'd like to go over each of these, or most of these, in the next few slides as well. Just, I suppose the most important point here is that rehabilitation starts on admission. Yeah, so it's really at the first point of contact. And some of you might even say, yeah, but only if the patient is medically and hemodynamically stable, right? But actually, no. We can already start with respiratory care. We can already start with positioning and compression. And I'd like to, so this is the next slide is an overview of the respiratory roles that is part of that rehabilitation. Now, this is, of course, for many, many different causes and reasons and purposes, not just in patients that have an inhalation injury, yeah, as part of having inhaled smoke or other substances that may have caused an injury to the lung, but also post-operatively, just like in other patients that are bedridden. So we really need to assess and screen and then treat the patients on the respiratory level. Now, these techniques are not different than in any other conditions, so we're not going to go over them, but this is just a good overview of what the possibilities there are and what the aims are as part of the rehabilitation on the respiratory side. And one of the main parts of a burn injury that we want to treat is edema, or in fact we want to manage edema. And the rehabilitation of edema, or the role of a rehabilitation staff here is primarily to elevate the injury, yeah, and elevate the part of the body part that has edema, particularly the limbs, yeah. And so we facilitate return of the fluid to the heart. That can be achieved through positioning, but also through splinting. We want to mobilize the patient and really move, and particularly the goal should be active movement to really activate that muscle pump, and then compression, which can be achieved through bandaging, of the different body parts. Right now, there's many reasons why edema occurs in burn patients. On the left side, you see some of the predisposing factors. In burn patients, particularly, there is, especially severe burn patients, this edema is not just only local, but is often also systemic. So it's really generalized edema. So a lot of the fluid really moves into the interstitial space, and that has, particularly in the acute phase, a very devastating impact on the patient. It doesn't only increase pain, it doesn't only reduce function and joint range of motion, but effectively it also deepens the burn wound, right? So it is, and that has a a huge impact on wound healing. So it has to do with the problem that the edema actually compresses and reduces blood supply, and so there's less exchange of all the different cells that are required for wound healing. And so it's really, really important to manage edema when it occurs in a patient. And sometimes it may actually occur only a few days after the initial injury. So it's really important to monitor as well for edema in your patient. Right, and now we've already talked a little bit about positioning in terms of for edema management, really elevating, right? But positioning, of course, is also very important in burns patients for other reasons, right? And you can see on the slide, you can see a knee or a lower limb of a patient that has been positioned in a flex position. Now, if that's positioned like that, it will very likely heal like this as well, meaning that we are developing a scar contracture, which means that this patient isn't able to move out of that flex position. Now, that's obviously something that we want to avoid. Some other example of a hand burn, particularly here the dorsal side of the hand, if that's not positioned well and not managed well, the scar contracture can end up as extreme as you can see here in the picture. So there's a couple of high-risk areas that we can identify in burns patient that are where those scar contractures are causing a lot of disability. And these are, as you can see from the pictures, the face, the neck, the hands, and the axilla, right? And so those are the parts of the body where a lot of skin mobility and flexibility is needed for range of motion. Yeah. So making sure that that if you have a patient with a burn to that location, we need to be very, very careful of how we position the patient and how we treat the patient, and we need to be aware of how to manage and prevent those scar contractures. That's important because scar tissue can only stretch 15%. And normal skin, so prior to the injury, can stretch up to 60%, right? So that scar tissue is a lot less flexible, lot less mobile, right? And with that being said, children grow, so particularly children, that's an issue, but scars, they do not grow, yeah? So we want to be aware of these locations, and also with particularly paying attention to pediatric patients. Now, where do people develop scar contractures, and how, particularly when they're being left in positions where they're comfortable? Yeah, and those comfortable positions is usually the embryonic position, where patients sort of go back to, and so we need to prevent that. The way that we can, in general, position a patient is with these, as you can see on the slide, this what was also known as the aeroplane position. And so we want to abduct the shoulders to 90 degrees, want to externally rotate them, and horizontally abduct them, particularly if there's a burn injury to the chest. And there's different positions for the elbow, which of course we want to have extended. There's another position for the hands, so we want to have that sort of safe position of immobilization, the posy position, and then dependent on, if there is, depending on where the injury is, we might also want to position the neck and the legs in a certain way. So the neck's legs, as you already saw in the previous slide, should be extended and slightly abducted and slightly external rotated as well, if possible. Now, ultimately, there's many different ways to do that. Here you can see a bit more of a higher income setting, with very nice boots and a very good hospital bed. But really, you should try to make use of anything that you have. So from pillows to tables there around, so we can really make use of those. Make use of different kind of slings. Try to use anything with looking at sterility. Not sterility, but like infection control. So that's also, of course, important in order to position a patient well. Now, just a couple of pointers. If there is an injury to the neck, to the interior neck, so the front of the neck, then you want to position the patient not with a pillow under the head, but really pillow, maybe a roll under the neck. So their neck is in an extended position, because ultimately what you want to do is you want to elongate the position or the area of the burn. So it heals in a good position. If the burn is on the back side of the neck, you want to do the opposite. So there's no one size fits all rule that comes to positioning, but really in function with the burn injury and the location of the burn injury. Now with the hand also here, so if unless there is a certain depending on where the burn is, want to position a patient hand in this kind of way, that can be achieved with a roll or a towel to be able to actually avoid some of these contractions that you see in this baby toddler on the right side here. One thing I would like to really recommend you to do is to make use of a individualized positioning chart. And so this chart can be, you can take a picture of the patient, of how you'd like to position the patient, and then give some instructions of how you'd like to, how that patient needs to be positioned. That position might also need to change over time, right? Think about pressure, sore prevention, and then that can be communicated to the nursing team, to the family, whoever else is around, when you as the rehab staff is not around. Okay, now positioning sometimes isn't successful, and that may have to do with the fact that this position is painful, and so the patient might consciously or subconsciously move out of the position again. And so in this case, a splinting is indicated to be able to achieve that safe position, that anti-contracture position. And another reason is if you want to protect range of motion of the joint. Right? If you want to protect that deformity in the stretch and scar areas, but also if you want to protect a graft. We're going to go into those later. But grafts, when they're being placed, there's a certain time in the first 5 days, particularly, that they're fragile. If it's a different types of graft, it might also need to be immobilized for a longer period of time. So in that cases, splints that can be fabricated for a patient indicated, and preferably we would use them before the scar contracture has developed. Now, just some examples. If for a neck, so here you can see a neck splint that's been created with suction tubes. So really this can be done. You don't need fancy thermoplastic materials around. If you don't have that, there's different ways that we can make use of other materials for splints, and that neck collar can really provide that stretch of the interior neck and the parts that you'd like to be the parts of the bone that you want to be stretched. And then if for the hands, we can, for example, also create a splint. I think here we have some form of plastic that can be molded to the patient's hand and wrist position. And on the right side, there's a QR code for some more innovative solutions from around the world, which can be used in low income setting and settings where there's limited resources. Now, besides positioning and splinting, what we also need to do in order to prevent contractures is to actively and passively mobilize the patient's bone. Now, this should happen as early and as quickly as possible, right? And so passively, we should be able to mobilize the area of the patient, and this can be done under general anesthesia or under sedation and under analgesia control. Now here's some pictures where you can see how that can be done, but really we want to stretch the burned area. Yeah. Now there's a couple of contraindications to stretching the burned area, and that is if the graft is still fragile. Yeah. So that's generally 5 days post-grafting. And of course, if there are other associated injuries such as fractures and exposed tendons and so on that are making the mobilization contraindicated. Now, of course, at this point, you're probably wondering, okay, so how do we really treat a patient that has undergone grafting surgery? If the burn wound area is deep enough or extensive enough, it needs to be grafted because it will not heal by itself. And so one of the most common grafts that you would see in a burn care setting is a split thickness graft. Now, based on this, after a split thickness graft, you want to know, first questions you want to know is, where is the graft located? Does it cross a joint, or is it near a joint, yes or no? If it's not near a joint, then we, in fact, can immobilize, I actually think that this isn't, showing up very well, because I think this, so I think this graphic was supposed to actually go towards this one. So if it's not near the joints, we don't need to immobilize the patient. We need to actually, so this arrow is supposed to go here. I'm not sure what happened exactly. Yeah, and so we need to check if the graft was taken, if it's a good graft quality, and it's not near joints. Then what we can actually do is we can progressively mobilize that with compressing the burn, the graft. Yeah, so using some bandages around it to ensure that the graft stays in place and isn't being moved away from the wound bed, and then we can progressively mobilize the patient. Now, and that can be done particularly after 2 days of immobilization. If there is a graft that's near the joints, then we want to immobilize that area for 5 to 7 days. After those 5 to 7 days, we want to check with the dressing changes, and we just check if the graft has taken, maybe there's an infection and the graft hasn't taken, but if it has taken, then we can go over to progressively mobilizing that place. Yeah. So main point here is that if the split thickness graft is near or over a joint, we need to immobilize it for 5 to 7 days. Make sure that you always consult with the surgeon, because the surgeon knows how good the graft is and what kind of graft was used, how the graft was being fixed, right? And so together with consultation with the surgeon, you can decide how and when to progressively immobilize the patient. Also understand that this immobilization doesn't mean the same as bed rest and not moving at all. Right? It just means we cannot move the affected body part. So we can still work with the unaffected body parts. They don't need to decondition with the time. One small point here about the donor side. So, with the graft, there is a skin taken from a healthy skin, basically a split thickness. So only half of the skin is being taken to transplant onto the burn wound area. That part can be mobilized right away, but is often extremely painful. So be aware of that. Now, mobilizations can also take place and should also take place in the operating theater or during dressing changes. And the reason for that is that it's during that time that we can actually, the bandages, the dressings are off, and you can actually expect the burn wound. So you know where the bone is located. Does it cross a joint? Does it not cross a joint? You can see if there has been a graft, a grafting surgery done. You can look at the quality of the graft. Has it been taken? Does it look good? Is there some infection present? Yes or no? And most of all, in terms of treatment, we can actually, if there is, depending on the level of sedation and paralysis, that will enable you to do some mobilizations that are pain-free. Yeah, so often pain will limit and restrict you from how much we can actually mobilize a patient's burn wound. And so if it is safe, keeping in mind the grafting protocol, we are able to do some pain-free mobilizations in the OR and during dressing changes, even if they do not take place in the OR, but under sedation. And so this is good because we can, as I said, understand where the graft is located, is the joint involvement, what does it look like, and most of all, this is also a very important role for you as potentially if you are a therapist, and we're not often used to working in the OR or being present during sedation and anesthesia. So this really is a great moment to actually interact with the surgical team, to interact with the nursing staff, to communicate with them. Where do we want to, what is possible with the patient? How do we do dressings after the patient has been operated on, or after the dressings have been changed, so that we can have some dressings that enable movement and function. And really to be part of that, multidisciplinary team and to get them on board with rehabilitation. Right. Of course, there's so many negative effects of bed rest, right? And I've just listed them here on the left side, but these are common and these are not exclusive to burn patients. But maybe one of the main issues here is that with burn patients, there is often no need, or there might be a need to immobilize them and for them to have bed rest, but that's very, very limited, and that's limited to the surgical immobilizations, maybe limited to some of the fractures, some of the other polytrauma that they have, right? But if it's once those have been resolved, it's very safe to really activate the patient and immobilize them. So it is really, really important to not let pain dictate what we do and what we don't do, but to really be informed about the negative effects and try to counteract this terrible combination of burn injury and bed rest. Now, muscle wasting here is one of the negative consequences of bed rest. But particularly in a burn injury, it's even worse because these patients are actually burning more calories after the injury than they used to before the injury. And part of that energy that they need for wound closure and for the whole healing comes out of the breakdown of muscle. And with being immobilized with bed rest, you see a lot of burn patients really, really lose a lot of that muscle mass. The more muscle mass is being lost, the more severe the complications. And one of the worst parts is the decreased immunity, increased risk of infection. Tom earlier was talking about how these are infection prevention is one of the most important aspects of burn care, and wound healing, right? So closing the wound, and the less muscle we have, the more difficult it is for the wounds to actually close. And this is something that we see in conflicts area where patients already come in emaciated with very little muscle mass left because of malnutrition. So really the key here is to prevent muscle wasting, to have good nutrition for wound closure, and to mobilize the patient as early as possible. Part of that mobilization is also active exercise. And so we want to get the patient up, we want to mobilize them as quickly as possible. On this image, you can see some patients who are being mobilized, who are ambulating, who are learning how to walk again. You can see some aerobic training, some strength training with some TheraBands. And so there's many different ways. And if they're within the limitations of what is safe and what's possible, then we should be able to move them and exercise with them. Strength training, aerobic training is all indicated in burns patients to prevent a muscle wasting. This needs to be done as early and often as possible, and also it should be done as functionally as possible as well, right? We've covered the faces of these patients, but if they weren't covered, you'll be able to see that these patients aren't really happy. So they're not happy to move, because it might be painful. And however, it's so important to really push them and motivate them to do it, because it really improves mood, increases independence. It just increases overall well-being of the patient and prevents those complications of scalp contractures and so on. Now, of course, it is very difficult to move with burns patients, and pain is just one of the factors that I mentioned. Fear, of course, another one. There's often bulky dressings around as well, which maybe are limiting some of the range of motion, some of this movement. The dressings, the burn wound might have dried up a little bit, and so the dressings might cause a bit of like sharing and a bit of movement of that healing wound. So that might be painful. There might already be some scarring and some scar contractures present. Patients might be systemically unwell. And then, of course, many don't realize how important it is to move, because there are beds in hospital. And so what else would you do but lie down on them and rest until you're well again or until you're healed again? So that's the thinking, the patient, but also the family. And so that's something that we really want to change, and we need to educate the patient. And then, of course, we have the surgical procedures that we've already talked about. And so just to go through over some of these, so pain is a key aspect. We need to manage pain before we can exercise and mobilize the patient. And so one of the very simple things that we do is we try to get a pain score and then give analgesia half an hour prior to the exercise session. So the timing of exercise really matters. Keep in mind that there are some procedures during the recovery of a burns patient, such as dressing changes and other procedures that might be very painful, right? So make sure that the timing of the exercise session keeps that in mind. And so it's really important to coordinate and to communicate with the treating doctors, with the nursing team, right? We need to educate the patient, the family, and everybody around, and then reassure, encourage, and play. There's also some other techniques that have been used, particularly during some of these painful procedures, and these could be relaxation therapy, imagery, virtual reality, if that's available to you. It's all something that has shown to actually have an impact on the pain perception of the patient, and then the cooperation during some of these procedures, including exercise. So pain should never be a reason not to exercise. Right. And for children, of course, it is incredibly important to play. Not just for children, also for adults, So if you can make something fun, exciting, then we can stimulate movement. Just one thing I wanted to show here, of course, we're not be able to go too much into pediatric burn care, but so if there is an injury to the anterior side of the neck here in the chest, you don't want to have a game where the kid is pulling a toy with a string, right? Because that actually encourages flexion, right? So we want to have a balloon, something where the patient has to hit above the head, so you can really the patient can really stretch the affected area. Yeah. So this is so important that you try to keep in mind the location of the burn injury and adapt then the treatment. Right, just one example of what dressings could look like if they are done in a way that do not encourage movement of the fingers. So sometimes, if there is if you want to mobilize all the fingers and the hands, but you have dressings such as this on the left side, there's very little that we can actually do with that, right? So this is just an example of how important communication is with the staff that is in charge of doing those dressings, right? So if you are present doing the dressing changes, and if you can communicate with, hey, I would like to have the web spaces free. I would like to have, is it possible to do dressings where, the patient is able to actually train some of these, the fine motoric skills of the hand and so on, right? The multidisciplinary team is incredibly important. And this also is a good gateway to my next slide, because often, in your rehab team, you have so many different professions with different expertise and different priorities. And how is it that we can pull in the same direction and not tighten the knot even more, right? So teamwork during an emergency is essential. And patients really need to hear the same message